I request Dr. Subhash to present his talk on MED.
And thank you, Dr. Pandey sir, for including me in this IC. I will be speaking on monocular elevation deficiency diagnosis and management. Basically, it is defined as inability to elevate paretic eye from any position of gaze provided ductions are normal in all other positions of gaze. It may be due to paresis of superior rectus and inferior oblique with ptosis, or it may be a long-standing superior rectus palsy. Initially, the term was double elevator palsy, which was coined by Dunlop. It may be congenital or acquired. It may be paretic or restrictive. It may be supranuclear. Now, the term which is more commonly used is MED. It is more accurate term because paralysis of both muscles independently and supranuclear lesions can lead to impaired unilateral upgaze palsy. So now, most oftenly, the MED is used in place of TEP. Causes could be congenital, which could be supranuclear defects, SR paresis, inferior rectus restriction, neonatal hypoxia, in acquired CVS disease, midbrain tumors like pineocytoma, acoustic neuroma, and metastatic tumors, sarcoidosis, and cysticercosis are other causes of acquired MED. It has been classified into type 1, 2, and 3. In type 1, the prominent feature is restriction of the inferior rectus. In type 2, weakness of the elevator weakness is the prominent feature, and in type 3, it is combined type. So clinically, there is limitation of elevation above midline, both in abduction and adduction, and it is very important to differentiate it from Brown syndrome. Then there could be hypertropia of involved eye, and there is presence of ptosis and pseudotosis. Usually there is chin elevation. Usually it is unilateral. Marcus gun jaw winking phenomena is seen in approximately 25% of the patients. This is clinical photograph of one of the patient with the MED. So for diagnosis, it is very important to ask history of onset, and if sequence of events is not clear, then presence of amblyopia suggests congenital etiology. You must look for previous photographs. In acquired cases, there will be history of neurological symptoms. You must ask about past medical histories and general systemic symptoms. In type 1 MED, positive FDT will be there, normal FGT, normal skates, and deeper lower lid folds. In type 2 MED, their FDT will be negative, reduced saccadic velocity will be there, reduced force generation, Bell's is intact, and absent skates above midline suggest supranuclear lesions. In acquired MED, there is acquired diplopia in upgaze along with presence of neurological symptoms. Usually ptosis is not a prominent feature in acquired MED. It may be associated with pupillary anomalies and convergence weakness. Bell's phenomena is usually present, and patient assume a chin-up head position. This is a case of 20-year-old female with post-traumatic MED. FDT was suggestive of tight IR. This is another case of 30-year-old with right acquired MED. His case of sarcoidosis with high age level and high lymphadenopathy in HRCT chest. Another patient, 20-year-old female resident of Delhi, presented with chief complaint of diplopia since 1 month. And on imaging, it was found to be case of cysticercosis with cystic lesion in the inferior rectus muscle. This is MRI. And after medical, he managing the patient with oral albendazole and steroids. Patient was orthophoric, and elevation limitation also got resolved. So basically, how to differentiate congenital and acquired MEDs. Congenital MED is usually in children. Acquired MED is usually in adults. Age of onset is at birth in congenital MED. However, in acquired, it can start at any age depending upon the cause, but more often in older patients with diabetes, hypertension, atherosclerosis, or serious disorders. In congenital MED, strabismus and ptosis are the prominent feature. However, in acquired MED, acute onset diplopia is a primary feature and ptosis is not a prominent feature. Systemic status, there is no relevant systemic disease. However, in acquired MED, cardiovascular neurological diseases may be present. In congenital MED, amyloidopathy and suppression are common. However, in acquired MED, diplopia is more common. Various differential diagnoses for congenital MED could be Brown syndrome, vertical Duane's, congenital fibrosis of inferior rectus, congenital absence of superior and inferior oblique, absence insertion of inferior and superior rectus, and superior divisional third nerve palsy. Differential diagnosis for acquired MED are thyroid orbitopathy, myasthenia gravis, orbital floor fracture, third nerve palsy, orbital cellulitis, orbital inflammatory diseases, cerebral tumors. This was one of the patient with ocular myasthenia gravis, which presented like MED and was referred to neurology department for management. Then what are the indications for surgery? In MED, significant abnormal head posture in primary position, significant vertical deviation in primary position, contracted binocular fields, and diplopia in primary gaze. They are the indications for surgery in cases of MED. And in most of the patients, we have to observe the patient because the patient can manage orthophoria with limited head changes. Treatment for MED is surgical and only surgical. So what are the goals for surgery? We want to achieve cosmetically acceptable deviation in primary position. We want to increase the field of binocular single vision, and it is very important to tell the patient that surgery will not cure it. And more than one surgery is required in this sort of patients, and usually these patients, they present to the ophthalmologist with complaint of ptosis, and they want ptosis surgery first, so they have to be consulted that strabismus surgery will be done first, and after that ptosis surgery will be done. So counseling is very important in this sort of patients. So what are the various surgical procedures? Optical treatment for MED remains controversial, and treatment should be according to type of MED. And in type 1, which is usually in approximately 75% of the patients, recession of the involved inferior rectus is the procedure of choice. In type 2 MED, NEPS procedure is a well established and commonly practiced procedure. However, NEPS procedure has its own drawbacks because patient loses some ability to abduct and adduct, and effectivity decreases if deviation is more than 25 prism diopters. These are the steps of NEPS procedure. So basically this NEPS procedure was described here. There is vertical transposition of horizontal muscles to the SR insertion. Then this NEPS has been modified in cases where there is associated horizontal deviation with elevator weakness. So in this case, there is transposition of superior half of equally divided up to 15 mm medial and lateral recti for vertical deviation, and inferior half after suitable recession and resection is used for horizontal deviation. This was published in Journal of Ophthalmic Surgery and Lasers. Esotenotomy and vertical muscle recessions have been found to be effective modality in congenital MED in one of the Chinese study. Then Sneer M. et al. Recommends NEPS procedure with posterior fixation sutures, and MED with modified NEPS is done for double elevator palsy with horizontal deviations. These are the preoperative photograph of one of the patients, post-operative photograph. This is pre-op photograph of another patient. This is post-operative photograph. This is pre-operative photograph of another patient. This is post-operative photograph. Pre-op photograph of another patient. So this patient is case of congenital MED, and this is the post-operative photograph initially after doing the squint surgery and finally after doing the ptosis surgery. So when to intervene for ptosis? So minimum of 6 month waiting is required after squint surgery because magnitude for vertical correction increases with time following NEPS procedure. Thank you.
Thank you, Dr. Subhash, for a very informative talk. I think only thing is if you are doing IR recessions and if you are doing more than 6, then you need to have little medial transposition because it may produce an A pattern because it's also an adductor. So if these are very tight and there's a lot of hypodeviation, hypotropia, if you're doing more than 6.
Sir, usually I limit my recession to inferior rectus to 5.5. I am not going for more than 6.
But some are really tight, and I think you do need once in a while need to do more. But in general, if you're recessing IRs, you should be careful about that.
Yes.
And some cases you can also do IR recession and SR resection where the deviation is not too much. And of course, it's
some
not.
studies have been there in the literature, and one of the studies have been done from our center also. One of the thesis was done in which this inferior rectus recession and superior rectus resection has been used, and they have been found to be useful.
Especially if it is not a large deviation.
Yes.
Because NIPS has its own issues. Dr. Pradeep, would you like to say something?
Yes, I think these are the options. And in addition, even the contralateral elevation, elevator muscles can be tackled in situations when we have already had a deviation which is not correctable by the same muscles being surgery. So the other eye, we have used the total antero positioning on the IO, the inferior oblique, which is an anti-elevator. So you can have the anti-elevator effect on the contralateral eye to correct the problem of the MED and balance the two eyes. And both the eyes can be then having a...
Yeah, especially if there is a ptosis in this eye, if you recess the contralateral SR, that works quite well because that by in the contralateral
eye along with an IO tap.
Yes.
IO total antero positioning.
Yeah.
That may also balance the thing. So what you said is right, that first is FDT, IR recession is the first choice if FDT is tight.
Yeah.
If FDT is not tight, then you can do a NAPS or a NAPS with posterior fixation sutures. And the third option is then to do the contralateral elevator muscles.
Yeah, if there is pseudotosis, that part will be corrected, and if there is residual ptosis, that can always be corrected later. So I think that sums up the management for the MED.